Dear friends, happy to be among you, at least virtually, and to speak something about alternate alignment future. Huge honor for me to be invited to such prestige meeting, and I'm really sorry it cannot be personally there. My name is Dragan Jeremic. I'm coming from central Germany, a huge arthroplasty center with considerable experience with kinematic alignment. Our restricted K has a good long-term implant survival and negligible incidence of varus failure. We know that with a lot of meta-analysis, it's shown that we have a favored kinematic alignment over other alignment issues in some functional, some proms. That the joint line is orientated much more to the floor, and that some forgotten joint score have better results and some proms worse, but is always very much noise in subjective measures that our patients use. As you see here, the papers are all over the world, and there is a wide acceptance on this alignment. We also know that in 7-year follow-up, then UKK piece done with the PSI has very similar results. We're all presumed MA alignment techniques, and also the randomized control studies showed that 13-year follow-up unrestricted TKA with Gangard, similar reoperations, complications, and patients reported measures. What is actually what TKA surgeons want to know? If you want to know what happens with alignment phenotypes when we operate, they want to know what do they affect clinical outcomes and what is the impact of prosthetic trochlear orientation. As well, how can we optimize PFG in TKA? The study that I wanted to show you identified patients from my single surgeon series. We had a 28 months follow-up and follow-up forgotten joint score and KUS, and assigned to CPAC category. CPAC is well known as a McDicey study. And you can see here what happens with alignment change. We have CPACs, varus, neutral, and valgus, and almost 22% patients change, 22 patients change their CPAC to neutral, but 36 left the varus alignment. All in all, we have a lot of changes, and this showed that we have 32.5 patients who stayed in same CPAC, and almost 2/3 changed CPAC. And that's very, very similar to the publication we have now in literature, who shows that also around 60% patients change CPAC. But does this affect in any case our clinical outcomes? Well, CPAC didn't show any difference, especially the varus CPACs. And you see here there is no statistical difference among the group in KUS and forgotten joint score. Overall results were very good, but if you watch on the right side, there is a like traffic lights for the patients with varus, valgus, and some neutral patients. Just group 4 has significant difference in comparing to other groups, or other groups are very, very similar. Patellofemoral abnormalities also play some role, but it's high prevalence among the in our study, but not associated with differences in clinical outcomes. And what is our goal in alternate alignment? Our goal is to optimize quadriceps function and reduce risks of patella complication with trochlear malrotation. We have like patellofemoral trochlear orientation and malalignment. We have K-specific prosthetic trochlear orientation and ceramic prosthetic trochlear orientation, and we have to bring them together in relation to quadriceps line of force. That means quadriceps line of force, I will tell that later, is possible independent factor of the results. The prosthetic trochlear angle should have the broader angle to 6 degrees to include all various valgus phenotypes we already showed with all the results I presented, and evidence that the minimum of KTS should be 70% to reduce the risk of medial deviation to the quadriceps vector in CPEC3. Here is the study from Australia that shows that most components have 6% of PTA, prosthetic trochlear alignment, and these studies show that we have a mismatch of around 41% of the patients, whereas the trochlear malalignment too narrow and does not match the native knee. 6% of prosthetic alignment should be increased to be a better funnel and to catch all the trochlear. Very recent paper from Simon Talbot, who's showing that extensor mechanism malalignment could play an independent role in all alignment issues that we have and be clinically relevant more than trochlear groove orientation. I repeat, it could possibly be that the quadriceps has individual line of force, and from that perspective, just the reconstruction of the trochlea doesn't always take us from the danger of to be a lateral patellar facet arthrosis. Reoperations in kinematic alignment are rare, and here's a designer study who showed that just 3%, 3 patients with female valgus had some issues with reoperation in anterior knee pain. And what's the rationale behind it? Means if it's the orientation of the MPTA 6 degrees, and with quadriceps vector who is divergent to the trochlear orientation, we will have the reoperation. If it's converging, they are don't we don't have it. Once again, study with from Stephen Howell from the patients, and that's the goal of that future understanding of kinematic alignment and patellofemoral orientation. That means the quadriceps vector should be medial of PTA, of patellotrochlear alignment, and just in that case we will have good normal patella tracking. If it's medially deviated, it means that we have some possible maltracking in the patella. 20% of quadriceps vector is good for all the patients, and trochlear orientation from 20% should be good for the kinematic speed and efficiency of our surgery. That's the newest results. Revision rate in the patellofemoral orientation malalignment is from 1.3 that I showed with patients from Howell study to 3% from Australia and New Zealand register in 7 years follow-up. What's actually a trochlear of mala orientation? Well, it means that we have PTO that sits medial to quadriceps line of force, and in our study it was relatively common. It's almost every third has some kind of TMO that adversely affected clinical outcomes with lower points in KOOS and forgotten joint score. Practically speaking, we have a patient selections. We have to know which alignment type do we have and which alignment type we address. In this situation, it's the CPEC2. We are doing pre-op trochlear malrotation test, and as you see here, we have convergence of the quadriceps line of force and prosthetic trochlear orientation. Then we are doing implant selection. It should be a case-specific implant. And on that way, our goal is that we do broader funnel to avoid problems in patella. On this way, we solve the other problems. We should be aware of alignment phenotypes. We have to be very good in patient selection, more than used to. We have to have implant selection for special cases. Schematic alignment mostly solved tibiofemoral joints, but nevertheless, everything was still in coronal plane. We are leaving the coronal plane and we are going to the age of PFG in KA. Thank you very much.